Hello, happy Teach Me Tuesday and last official Tuesday of 2023. I am Lisa Houston and I'm here with part 4 of our NRP series. We've been doing this every Tuesday of December, which actually was not planned on the first Tuesday, but then all of a sudden became planned and it's been pretty awesome. Yesterday was Christmas. I'm in a house full of people, so I'm recording in my bedroom today. So welcome to another location. But I have really enjoyed this series and kind of diving deeper into NRP. And so today we're just going to talk about how NRP is instructed, how we use simulation and debriefing to help us really dig into these key concepts and work on our teamwork. So if we review what we've gone over in kind of these last 3 weeks together in this month of December, we really can come back to these key concepts that never change. So I also feel like I need a disclaimer that every thing you see today is a mannequin, just in case anybody was wondering if I took pictures of a real baby with all the side rails down of their giraffe incubator. That would be kind of cuckoo bananas. So mannequins. But let's go back to our key concepts. Right at the top, we have thermoregulation. Thermoregulation is going to drive everything we do in NRP and in the NICU, let's be honest. And we know that for every degree a baby is too cold, their morbidities and mortalities increase incredibly. So keeping those babies warm while they're in the NICU is going to be essential. Then we focus on our ventilation. Is the baby breathing? If they're not breathing, if their heart rate's not rising, they are not effectively ventilating, and we need to help them. Teamwork, role identification. They go together to really help us understand how best we can serve these babies. Compressions, medication, and access, a whole chunk of the NRP algorithm that really kind of goes together, because if you've started compressions, someone's drawing up meds and someone's making sure you have access. They kind of all go together along with that documenter, and then this team coordination and really thinking about how is our team best serving each other. And the best thing that we can do as a team is to have a shared mental model and to be able to speak up and say, hey, I noticed this, or have we considered this? Are we on 100%? Have we switched compressors? So that we are having these open dialogue together. Then we talked about our secondary medications that come out when we're talking about NRP and prolonged codes, including sodium bicarbonate, calcium gluconate, things that we wouldn't typically give in a code, but if it's gone on for a long period of time, and especially if we are in the NICU and the baby is more, than that 28 days, that we might need some more of these medications. And then our ethical issues, really thinking about our babies that have known congenital anomalies, babies that we've been doing prolonged codes on, extreme prematurity. All that kind of comes together and all that we have learned. So if you've read the book and you've read through the book, you've prepared yourself for a class. So NRP is a 2-step process, right? Part 1 is you do this online learning where you're taking 2 quizzes, depending on if you're doing essentials or advanced. So if you're doing that advanced course, you've taken that 2-part quiz, and then you're going to show up for class. So what does this class look like? So classes really should have a minimum of 3 people so you can have this effective team training and stations. And it involves these specific and complex procedures. So we're going to sim them after the class. Typically, classes are kind of a classroom-based station learning, and then you go into a part of a simulation, whether it's high fidelity or an instructor just calling out what's going on. But it allows us to practice them and make sure that we can effectively perform the tasks that we would need to. In our classes for NRP, we often have, mixed professions. So sometimes we might have doctors, nurse practitioners, RTs, nurses. We have everyone kind of see what everyone's role is, so you would know what kind of the flow of the room should be, but never in real life is a nurse going to intubate, so we wouldn't necessarily have them intubate during the simulation. But if a provider's there, they would do that. If we were in a simulation and we got to this point where we needed to intubate, typically myself or another instructor would come in and do the intubation as a provider if we didn't have one there. So what should you expect when you show up to class? So typically, you're going to have some station-based learning. You're going to do equipment review. NRP teaches us, let's talk about one thing that is kind of universal, is the bags. So we have different types of bags, right? We have the flow inflating, the self-inflating, and the T-piece resuscitator. At the units that I've worked at recently, we only use T-piece resuscitators, but we still review all of those bags for the chance that maybe we need something different for a baby. We also use self-inflating bags for evacuation. So it's something that we are going to practice and do an equipment review of during an NRP class, because that might in fact be the only time that people see or get their hands on that. We go over collaboration. We go over role identification. What are the things that we need to be doing to help each other during these times? We have everyone look at our documentation sheet and be like, hey, where would you document this? Does this part of the documentation sheet make sense? So that when it's time to document in a code situation, they have seen it before. Everything is hands-on. Everyone's getting their hands on every item in the room. We go over our crash cart, kind of what you could expect in each drawer, what you might find in there versus in your bedside drawer, so that people are more familiar with what they're going to see. NRP has us do this every 2 years. So this is something that happens outside of our unit in a little simulation area, in a classroom area. And then we also are doing mock codes within our unit where we're kind of doing this in smaller little bits. But with the simulation, it really allows everyone to practice and repeat these scenarios multiple times. That repetition is allowing people to say like, hey, what am I doing? What comes next? What would I do next? Okay, every 30 seconds I'm doing this. Every 60 seconds of compression I'm checking a heart rate, so that it almost becomes second nature. Hopefully, you are not working in a unit that you are personally coding a baby every time you are there. I do think our shift lead team, that's kind of our charge nurses, our vascular access nurses, are seeing more codes than our bedside nurses, because we have such a big unit. They're going to go to any code, whereas a bedside nurse may only participate in a code that would happen in her little pod neighborhood area. But still, we want to be able to kind of know what to anticipate next. What is the task that is going to need to be happening? What is a time-sensitive situation? How long should this be going on? How long should I be doing PPV before maybe I would hit a code button? If I am called to a delivery, when would we call the team for more help? What is the next step in the algorithm? So the more that you can practice it, the more you can anticipate it. So along with simulation comes teamwork. So all these people are coming together, and this helps us in a simulated environment. Again, if you can see the cords coming out of it, this is a mannequin. A simulated environment to practice communication, coordination, and collaboration in a realistic scenario. If you have a Laerdal mannequin, the Laerdal has NRP actual scenarios where you're just reading off what's happening. They're kind of programmed in there. Again, you can do low fidelity where you're just calling out and saying, okay, there's a 36-weeker whose mom's on SSRIs. You're called to the delivery. Then you're just calling out the heart rate and the saturations. But in these environments where you do have high fidelity, there are things that are helping you in these realistic scenarios to effectively run your simulations. The healthcare providers are going to come together and do each part of those steps. They're going to practice their team training. They're going to practice that closed loop communication. Here's 0.2 mils of epinephrine for the UVC. I'm giving 0.2 mils of epinephrine for the UVC. So we've seen that, because then the documenter can write it down. So all of these are opportunities so that if we don't know what the next step is, we can say like, hey, this is what would come next. So we are in a simulated environment where it is safe to practice what we are doing. Because then at the end of every simulation, every scenario, which might be 5 to 15 minutes, it could just be these small little scenarios, we're going to debrief. And debriefing really is the heart and soul of the learning environment. In there, you are getting immediate assessment and feedback. You are saying, this is what I saw. What would you do if this had happened next? Would you have considered maybe checking the heart rate at this moment? It identifies areas for improvement. It allows us to receive guidance instead of going home and being like, I wonder if we should have done this. You get that opportunity to talk about it right there. It also allows everyone to practice debriefing, because debriefing doesn't just need to happen with codes and doesn't just need to happen in a simulated environment. Debriefing can happen within your unit after a code, after a rapid intubation, after a social situation, after getting a baby out to kangaroo care where maybe it didn't go well, after getting a baby out to kangaroo care where it went really well and you want to make sure you replicate it again. So this debriefing and simulation during our NRP classes allows a foundational learning and understanding of what to expect when you're talking about a scenario. In a debriefing environment, our goal is to ask these open-ended questions. What went well? What did you see? What did you hear? What were some words that were spoken that really resonated with you? What would you do differently? What felt tricky during this scenario? When did you feel caught up or frozen? What was care of the family like? So we had a family here. What was it like to talk to them? What were some things that you said to them that really made sense? What key parts of teamwork did you identify? So none of these questions are saying like, hey, Lisa, I noticed that your compressions aren't deep enough. You need to get your compressions deep enough next time. That is feedback that doesn't always feel great and can feel like a criticism. Instead, we're asking these open-ended questions of, tell me about the compressions. What's it like to do compressions in this environment? Did you feel like you were able to get into your rhythm of 1 and 2 and 3 and breathe in, 1 and 2 and 3 and breathe in? Did the depth feel good? And then people can recognize that. Asking, what's your key takeaway? What did you have in this learning environment that really resonated with you? That you're like, okay, this is when I'm going to use this in the future. And again, we're going to embrace the silence as the facilitator, as the NRP instructor, if you're a facilitator in just your unit, so that people have an opportunity. Not everyone kind of has that ready to go. They need to think. They need to reflect. If you've had video recording, that's even better because then you can play it back so people can see it. But embracing that silence allows the participants to describe their experience instead of you describing their work. It's one of the hardest things. I was taught to count to 7 after asking a question, and I think that really helps me to kind of pause and slow my body down. But in these NRP classes, we have done this station-based learning. We've now had this group learning in the simulated environment, and then we've had debriefing where it feels really safe to stop and pause and discuss. Because all of this is bringing us together to have effective resuscitations. So if we kind of, pull together our 4 times that we've been talking about NRP, in our initial NRP setup, right, we are focused on thermal regulation. We have our bed ready, our bed warm. We have the additional supplies that we need if we are resuscitating a small baby. The plastic warm, the thermal hat, the poncho, maybe a warmer that's going to go under the baby, additional warm blankets, whatever it might be. We're getting the appropriate team members if we know that it's a small baby, if we know that the mom has abrupted, right? We aren't going to just send one person there. We're going to have the right number of people present. In our NRP initial steps, remembering delayed cord clamping whenever the baby is vigorous. Then we warm, dry stim, get them on a heated surface. Watch for signs of vigor, right? Vigorous is, do they have tone? Are they breathing or crying? And is their heart rate greater than 100? So if the baby's doing that, if a baby's screaming and moving around, you can assume that they're pretty vigorous. And so in that environment, we may not need to do more. We're going to watch for breathing. Signs of effective breathing and ventilation are a heart rate greater than 100. If we don't have that, we are going to initiate our PPV. So signs of apnea, gasping, or heart rate less than 100, we are going to start PPV. We're going to utilize Mr. SOPA for decisions regarding what to do next. If our heart rate's not rising, again, we're going to reposition the head, get the mask in the right place, suction, open the mouth, change the pressure. We're going to follow our algorithm. NRP guides us for to do something about every 30 to 60 seconds, depending on where you're at. So ventilating, thinking about what our heart rate's doing. If our heart rate is rising, we are doing well. If you need 2 quick numbers to remember, it's going to be that 60 and 100. If your heart rate's less than 100, we need to fix our ventilation. If your heart rate's less than 60, we need to fix our heart rate with compressions and medications. So if you can kind of focus on those 2 things, you've really been able to take away those key learnings from NRP and put them into any code situation, whatever that might be. So this is a long slide. Feel free to snip it, read through it as you want to, but kind of trying to reassess the 4 learnings we've gone over during the month of December is just really kind of written out here. Everything that I've kind of been saying is, thermoregulation, ventilation, role identification, choosing your team leader, having your documenter have a voice to say, it's been 1 minute, let's check the heart rate, let's stop and auscultate. Going into the classroom and in simulation so that teams can become well-oiled, and then having an immediate debrief so that we can identify those key learnings and then maybe make some process improvements. When debriefing happens within your unit after an event, whether that's a code or an intubation or a tense situation, it allows participants to say like, hey, we didn't have a 2.5 tube in our intubation kit. So then we can be like, oh shoot, we need to put 2.5 tubes in our intubation kit. I know we all have 2.5 tubes. I was trying to think of something that we wouldn't necessarily have. Or we don't have porta warmers in our crash cart. So why don't we stock a porta warmer? Those warmers that go into the baby in every crash cart. That's a process improvement that we can do, but that's going to come out of debriefing. What we always say is where 2 or more are gathered discussing a situation, it probably needed a debrief, because then we can take that information and do something with it. So that kind of wraps up our December of NRP learning. I hope you've enjoyed this deep dive into NRP. I welcome your questions and suggestions. I will see you in 2024. Not quite sure which one I'm going to start off with in 2024, but it'll be exciting, I promise. And join me then for some more Teach Me Tuesdays. Have a wonderful and safe new year, and I will see you in January.